Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center, and I'm also the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Our topic tonight is survivorship and wellness, and our guest is Nicole Stout. Welcome, Nicole. Nicole
Hello,
is the Senior Director of Survivorship and Wellness for the American Cancer Society. And we've known each other, but we met for the first time, sort of face to face here this evening. So welcome.
Yes, thank you. Thank you so much for having me. It's great to join you.
And before we start talking about survivorship and wellness, let's get to know you a little bit. So, Nicole, where are you from originally? Where were you born?
Originally, I grew up in the Pittsburgh area. I was South Hills of Pittsburgh, and I did my formative schooling in Western Pennsylvania. So my undergraduate, and graduate degrees in Western Pennsylvania.
Okay, you're too fast because I really want to focus on high school. I have a thing about high school. I think
Okay.
your high school career can tell me a lot about you. So, how many were in your high school class?
Oh, it was a very small class. We only had about 150 in my high school class. Yep.
Okay. So I had about 150 in my high school class in South Dakota, but we would call that a big class. So, so what was your claim to fame in high school?
Well,
Don't be bashful.
I was an athlete in high school. I was a runner, a cross country and track runner, fairly decent. And I was a sprinter, hurdler. You might not, if you meet me in person,
wow.
I'm only 5'3". And so you may say, whoa, you were a hurdler, but that's what speed will get for you. So I was triple jumper, hurdler, javelin. So that was high school. That was a long time.
Wow. So what was your best finish in whatever tournament you want to tell me about? Did you get to go to the state tournament?
Yeah. Triple jump was my best event. And I did go to the state tournament in triple jump from our district. Yes.
Wow.
2 years.
Awesome. And then where did you go to college?
I went to a school called Slippery Rock University. Don't know if it is a real school called Slippery Rock University. It's a state school in Pennsylvania. And I went there, a Division II, because I had an opportunity to pursue running track at Slippery Rock, which didn't last very long.
What was the mascot of Slippery Rock?
At the time, now today they have a different mascot. They've changed it a little bit.
I won't judge.
Back in the 1990s, when I went to school there, our mascot was a rock.
I thought it was going to be a Native American name that you couldn't have.
No, not at all. Okay. It was Rocky the Rock, and it was a young man who would dress up in sweatpants and a hood that looked like a rock. And but that was Rocky. So today, though, they have a mascot that's a lion, which nobody likes because it's the Rock is the nickname of Slippery Rock University. It is the Rock. I just had the privilege of going back and delivering the commencement speech for the Graduate School of Health Professions, and it was nice to be back at the Rock. So if there's any Rock folks out there, go Rock.
Wow! And what was your first major? And you started
at Slippery Rock. It was my first major was in athletic training, but that's not where I finished. I finished with a major in community and public health.
Okay. And then you mentioned you went to graduate school.
Yes. That was a master's degree in physical therapy at Chatham College in Pittsburgh also.
Okay. And then what was your first job when you got out of your graduate program?
I went big. I left Chatham and I went to Penn, Hospital of the University of Pennsylvania. I moved to Philadelphia and took a position at Penn. And I was there in the Philadelphia area for about 8 years.
And you mentioned master's in physical therapy. Were you a clinical physical therapist?
I was. I started my career clinically. And the focus there grew very quickly into cancer, chronic pain management and cancer really very quickly. And my career became a focus interest, which again, at the time in the late 1990s, cancer and rehabilitation, cancer and exercise were really not a thing. Survivorship really wasn't a thing. So it was a little bit of an odd, new, emerging area, a little bit of an odd pursuit for me in career choice at the time, but it's worked out very well.
And do you remember some of the clinical situations that led you to go on and develop programming related to cancer specifically, as opposed to, hip replacement or shoulder uh,
Yeah.
rehab?
I think we say physical therapy, and a lot of people go, "Oh, my back or my hip or my," yes, exactly. But at the time, what I came to learn, I was working at Penn and doing a lot of manual therapy and chronic pain focused work. And we had the opportunity to develop a cancer and rehabilitation program. I mean, Penn is a all-star, top-tier cancer center in the world. And we had a physician who came from Memorial Sloan Kettering and wanted to start a cancer rehabilitation program. And the offer came out to our department for folks to go get trained and to help to support the development of this program. And there wasn't a whole lot of interest. And I sort of took that on and said, try it, something different. I didn't know anything about cancer. But when you find something that you just love and you just develop a passion for the knowledge and crave that, it was a phenomenal way to start my career, thinking about what I saw was the opportunity for rehabilitation to really change the lives of individuals going through cancer treatments. They recovered from surgery faster. They were able to get back to work much more quickly. And, knowing what we do in rehabilitation, we look at the problems, we solve the problems, we bring about interventions that help to remediate pain and fatigue. It was just a perfect fit. But nobody was really doing that at the time. So it was a little bit of a novel pathway. And because of that, then I started collecting data and doing some research and had an opportunity to then completely shift my career into a clinical research track.
And tell us a little bit about the research that you did and some of the results that have led to, eventually to you becoming the director of survivorship and wellness for the American Cancer Society.
Yeah, I think the honest truth is I got a little bit lucky. We were doing some novel things. I was presenting some of the data at a conference, and two individuals approached me when we presented some of our early rehabilitation interventions in cancer data. And they said, "This is exactly what we want to do. We've opened a protocol and we need somebody to come and run the research project." Well, where do they live? They lived in DC, in Washington, DC. So Bethesda Naval, it used to be called Bethesda Naval Medical Center. The Breast Cancer Center is where the protocol was open, and it was collaborative with the National Cancer Institute, the Rehab Medicine Department at the Clinical Center at NIH, which right across the street. I think you know that area well, don't you?
Yeah, so I actually was radiation oncologist at the Bethesda Naval Hospital and an instructor for the residency program at the National Cancer Institute. So when were you there in Bethesda?
Yeah, I started that position. I was there in 2004, and I was there until 2012.
Okay. Wow.
Mhm.
Yeah, I was there from 87 to 89, so a little before you.
A little before me. I was still jumping hurdles at that time. Yeah. So
Yeah.
yeah,
So, you created at the time that you were there, was it still called Bethesda Naval Hospital, or
it
did it
was.
change
It
its
was.
name to it's changed its name to the Walter Reed Army
Yeah.
Navy Medical Center at Bethesda because they closed the old Walter Reed Army Hospital. So,
Mhm.
and the patients that you had the opportunity to serve, were they, active duty military? Were they dependents of active duty military, or was it the patients that are receiving treatment at the National Cancer Institute, or both?
So I was a civilian working for the Department of Defense, centered there at the Naval Hospital in the Breast Cancer Center. So the research protocols were designed for a prospective surveillance model. And what we did was we introduced rehabilitation, physical therapy consult at the point of diagnosis. As soon as someone was diagnosed, we would do an assessment to understand their function, and we would follow them prospectively 1 month and then every 3 months after their surgery throughout the first year of treatment, just to look for changes in function and then to manage them. So most of the patients that I saw were dependents. And I think sometimes people are surprised when I say I worked at a military hospital. I did not treat, there were a portion of my population that were active duty military women, but the majority were dependents. And I don't know
Yeah.
that many folks realize how important that is to military medicine. You know, they talk about force health protection, and it really is about the entire force, which is the family members, the spouses, the children. So we treated all of that. So I started in breast cancer, and we were so successful with the work that we did with prospective surveillance that all of a sudden the head and neck, the ENTs were going, hey, wait, I need this for my patients. And then the thoracic surgeons were saying, wait a second, I need this for my patients. Where's my physical therapist? And so we really were able to scale and expand the program. So I was there until 2012. The research protocols were what I would say were wildly successful. The publications really transformed the way that we provide rehabilitation for individuals with cancer in an outpatient ambulatory setting by introducing rehabilitation early. Recovery is better. We detect and prevent things like fatigue and lymphedema to a high degree when we can do an early intervention protocol. So
Right.
yes,
And
it was active duty, but most of my patients really were family, were spouses.
yes. And did you do, as you were developing the program, and you mentioned, yes, you started with breast, but then head and neck and
Mm.
thoracic. How about pelvic floor physical therapy for gynecologic and urologic cancers?
Yes, and in fact, that's such a highly specialized area of practice. What happened at the Naval Center was that the GYN Oncology Service actually hired their own, another physical therapist. I was not a part of the rehab department in the hospital. I was hired and embedded into the cancer center. So this wasn't a, hey, let's send you a referral to go next door or downstairs. I was literally right there with the surgeons in the breast clinic. So we did mimic that that as a clinical program in GYN oncology, again for those very reasons. Hired a specialized physical therapist, had her in the cancer center adjacent to those service lines for surgery.
It sounds like, I mean, just listening to you and meeting you and your personality, I imagine that you were very welcome in the cancer center and probably had mostly lots of support. Was it universal, or did some people think, oh, we need to be focusing on killing cancer cells, not?
The
Did you
support.
have
I
any resistance?
Yeah, no, I have to say my biggest champions were the surgeons, the breast surgeons who walked alongside me, who worked very closely with me, were some of the biggest champions that I had. They were all about how do we do a better job for these women, not only the active duty women, but all women, because many of the surgeons knew in military medicine and in the military, physical training is an important component. Health is an important component of their lifestyle. And they said, why do we neglect this when somebody has cancer? All of a sudden, they need to be exercising. They need to. And so they were some of my biggest proponents. My radiation oncologists were some of the biggest proponents of this program because the modality of radiation therapy introduces a lot of challenging complications with scar tissue, with mobility, rib cage tightness, breathing, etc. And they would see those things. They were like, "Thank goodness, I've got somebody who can do something about these." So they were all very, very big proponents of the work and of the program. Yeah.
And then, have you had the opportunity and the pleasure to see how your research has been put into play at cancer centers, such as, we're doing this at Mercy One Cancer Center in Des Moines, Iowa. Have you had the opportunity to work at other cancer centers, either coaching or leading cancer centers into developing their own cancer rehab programs? Not everybody calls it that, but there's different titles that different centers might use for incorporating these services into the cancer center.
Yes, and I really think about it as embedded services, right? Because sometimes we think, especially with rehab, it's this referral and it has to go to this specialist who's in a different gym or a facility 2 blocks away, or this nutritionist, right? This dietitian that's in an office in some other building. When we can bring those services and embed them into the cancer center or have them very closely co-located, we can do consultative services right there with
Mhm.
patients when they're in the clinic, seeing the physicians. So yes, I've had the opportunity to work closely on grants to help to facilitate implementation with organizations like Huntsman Cancer Center out in Utah, with the
Mhm.
University of Utah. Worked closely with them. I've also done a number of work in consulting, helping other facilities identify training opportunities, provide training. I do a lot of education and training around the cancer space for rehab professionals. So I've worked with really all over the country, hospitals from rehab facilities like Brooks Rehabilitation in Florida, who has a phenomenal navigation program with rehabilitation providers providing navigation services. So really, there are a lot of different ways, like you said, to get these lifestyle behavior medicine type of services integrated into cancer care delivery. But it really takes a different vision and it takes research. And that was where our work was so important. So one of the most important things that came out of the foundational papers that we published, you publish a bunch of papers and you say, well, great. But it ends up like that scene in the Indiana Jones movie at the end where they're all excited about the finding of the Ark of the Covenant. And at the end, it's in a box and they're just pushing it back into the warehouse. And it looks like every other box, right? That's my paper right there going to sit on
Yeah.
somebody's shelf. But in 2012, the American Cancer Society, I worked with them as a volunteer leader to bring together an international consensus around prospective surveillance in breast cancer. And so we brought in a large group of subject matter experts, created a foundational care pathway, and that was published in the journal Cancer in 2012 as a preferred model of care delivery for breast cancer rehabilitation, and not just rehabilitation with physical therapists, occupational therapists, but also bringing in components like social work, nutrition, psychological counseling, social work, sexual health, etc. So really, it's about creating what we have done and help to facilitate is to create an entire system of care that walks alongside the patient, helps to support them, and brings about that service or that support when it's needed during the care continuum and beyond.
Right. You make so many important points, and the idea that having these services in the cancer center, because there's patients going through the cancer journey have so many things on their mind and on their plate, and sometimes the idea of making another appointment on another day in another building or even halfway across the city, it just even though they might think it would be helpful, it becomes a barrier. And so if you can bring everything into the cancer center, just makes it so much easier, and patients are more likely to actually engage in those services that will be quite meaningful to them.
Absolutely. You're singing my song from my
Yeah.
song sheet. Yes.
Yeah.
Greatest hits of Nicole Stout.
Yeah.
Get the services into the cancer center so that it's co-located. Because you're right, the burden of another day off of work, another place to park, another place. When I'm not going through cancer treatments. I'm seeing a doctor for something, and if you tell me I need to go somewhere else I haven't been before, another appointment, where am I going? Where am I going to park? Can I even get something to eat there? It's a stressful situation. Add to that, it's one more appointment on top of, and another, is it pre-authorized? Is my insurance covered? All of those things going through someone's mind add burden. The more that we can reduce that burden and bring those services right there alongside the individual, we've created in some of the cancer centers I've worked in, we've created an opt-out model. And basically, when the patient starts to report escalating fatigue, we don't say to them, oh, do you want me to send you to rehab? Because it might be a really good idea to get you into an exercise program. We document it. We have the exercise professional or the physical therapist reach out to the patient, and at the next visit, meet them and say, I heard you were having some issues with this. Let's talk about it. How might we develop some type of a program that can help you with these things? So that co-located service, that sort of, I call it the drive-by consultation, that can result in behavior change, engagement. You start to build trust with the patient, and they know that somebody's listening to them about this problem that, well, should I talk to my doctor about the fact that I can hardly walk up and down my stairs at home? That's not the doctor's problem. They're solving the problem of my cancer. No, but if we have that individual right there to speak with the patient and ask them about their function, how they're getting around at home, just starting the conversation, boy, does it open all of the opportunity for us to identify the problems, meet them where they're at, literally and figuratively, and help them to get through with sometimes just some simple suggestions and interventions.
Right. And you develop the trusting relationship, and it can bring in all of the other services as they start to open up about other issues, sexual issues, which, historically have been questions that doctors have been embarrassed to ask, and patients feel like, well, I'm not going to bring it up because the doctor didn't bring it up, and the doctor thinks, well, I'm not going to bring it up because the patient didn't bring it up. And so the more you get this trusting relationship and start providing these other services, you really do get the opportunity to know the patient and their needs more holistically to be able to take care of it. When we first chatted today, we talked about, the importance of survivorship, but also why it's becoming even more important as we have improved cancer treatments and reduced mortality by 30% in 30 years. And as a consequence, we have a lot more cancer survivors today than we did 20 years ago. Maybe highlight for us the reason the American Cancer Society is now focusing on survivorship and wellness.
Sure. It is just as you have said, Dr. Deming, it is the sheer volume of individuals. And that is a testament to the sophisticated therapies that we now offer to patients living longer and surviving to much, much higher degree than we've ever seen before. It's truly unprecedented. But, today in the US, we have 18.5 million individuals who are survivors. And we define that based on really anyone who has had a cancer diagnosis, either living with ongoing treatment, has completed treatment. We consider you a survivor. So with 18.5 million survivors, you may say that's fantastic, right? That's people surviving cancer, which is absolutely good news. But here's the flip side of that. About 60% of those people suffer some type of functional morbidity that disables them from getting through their day. Either fatigue, they can't do the things and activities that they want to do. Sometimes cognitively, they've changed. They can't go back into their work environment. Sometimes they have a more significant disability. They've lost a limb, or they need financial support. So all of these things that cluster and occur during cancer treatment, they don't just magically go away, most of them, when the individual is done with treatments. So while an individual is moving through cancer treatment, they're experiencing side effects of treatment. Some of those side effects may persist. Some of those may become chronic and cause other chronic complications. Other side effects may not present until months or years after the completion of treatment. So with 18.5 million people today who've completed cancer treatment, 60% of those experiencing some type of complication that they can't get through their day, sleeplessness, fatigue, depression, anxiety, you name it, there's an entire list of very prevalent situations and conditions that individuals face. That number of survivors is expected to eclipse 26 million in the next decade. So this is a societal problem that we're talking about, especially as we're starting to see younger individuals diagnosed with some of our most common cancers like breast and colorectal cancers. We've got to think an individual who's diagnosed with breast cancer in her 30s or 40s may live another 30 or 40 years. But if she does so with morbidity that she cannot complete her daily activities, she can't play with her kids, she can't go back to work, she can't, get through her days and needs support, then we've got a significant burden to deal with. So that's really what survivorship is. It is recognizing that anyone at any point in the care continuum and beyond, from the time you're diagnosed for the rest of the lifespan, we want to look at you differently, and we want to be able to support you regardless of those needs. You made the point earlier about sexual health. Financial health is another area. I think, patients think, oh, I can't talk to my doctor about that. They don't care. It's my problem to deal with. But all of this is about, people need to live after cancer. They need to live well, though. It's not good enough for us to say you've survived cancer. You should, just maybe deal with these pain, these problems, this fatigue, this neuropathy, this tingling that you have, the balance problems, the cognitive brain fog. I just might have to live with that. You know what? It's not good enough for us to say that anymore. And the reason is the evidence around lifestyle interventions like exercise, nutrition, cognitive and behavioral therapies, rehabilitation. The exercise is way too strong to suggest that if we introduce these interventions early, we can mitigate and even prevent many of these long-term and late effects that folks experience. That's a big deal when you're talking about 26 million people.
Yeah, you make so many good points. One thing that has always bothered me about the way some cancer doctors practice is, I understand that getting rid of the cancer is sort of job one, but if you don't see your patients back, several years after the treatment, you may not realize the amount of late side effects that patients have. As a radiation oncologist, some of the real fibrosis, the loss of elasticity, range of motion, those don't happen for years sometimes afterwards. And if you only see the patients, 1 month after they follow up with treatment and their acute side effects have gone away, you don't really realize some of the really life-affecting late toxicities. And then obviously you throw in the combined effect of surgery, radiation, and chemotherapy, and the late effects on the functioning of the heart or the functioning of the kidneys. Some of those we don't really see for years. And many patients, that transition, especially for that group of patients that are fortunate enough to become cancer-free, historically, they often kind of get kicked out of the cancer center, and primary care doesn't historically have the knowledge base of what some of these late side effects are. In our cancer center, we sort of have two survivorship clinics. One is the survivorship clinic that patients are cancer-free, which can change with one scan, but then another survivorship clinic that we call Living with Cancer, where we know that the individuals are survivors, but they're not cancer-free survivors. And philosophically, there's a big difference philosophically in those two different groups. But the support that they need from a physical point of view, whether it is massage, physical therapy, acupuncture, pelvic floor, or the psychological needs, or the financial needs, the spiritual needs, sexual needs. Those are all things that we get to provide the patients wherever they are in the continuum.
Yeah, I think that is an important point, and it will become a more important point. We cannot rely on with providing these services only within the four walls of our cancer centers. It isn't good enough. Because people don't want to, if they've completed treatment, they don't want to come back to that cancer center to see the dietitian or to see the social worker. Why can't I find someone in my community? Why doesn't my primary care doctor take on my care? There are patients for whom, treatment is enduring, and that isn't, some of them have advanced cancer and will be on some type of temporizing treatments forever. But at each one of those punctuated time points where a treatment is introduced or a new treatment and changes, we've got to reassess and understand, how do the new side effects present? How are those impacting your quality of life, your well-being? Some patients are on hormonal therapies, our breast and prostate populations for years, bone density, cardiotoxicity. There's so many things to think about. But really, you bring it all back down to, yes, the disease treatment trumps all. That is the most important thing that we need to accomplish through the delivery of cancer care. But we cannot neglect the support of the individual, again, with exercise, behavioral therapies, interventions with nutrition, social support. Those are critical components to these individuals. And if they're living longer, we've got to be able to walk alongside them for a longer period of time. And that might mean developing capacity in our communities. How do we develop? What does an onco primary care look like? What's the opportunity for that to be out in the community, a locus of medical care and supportive care in the community? Does that look like a primary care facility or a network that brings in the support care services, just like you've described, but it's in the community at a wellness center, an aging center? Can we bring that wraparound service alongside the primary care? Community health workers, how do we use them to help us better engage this population? But the sad truth of that is, as you've alluded to, the primary care providers, and I'll say capital P, because it isn't just physicians, it's the nurses, the nurse practitioners, the community health workers, it's the case managers in the communities. They don't know cancer. They don't understand sometimes, or don't have the knowledge about the long-term and late effects of cancer treatments. They're not looking at that woman who's had left chest wall radiation and an anthracycline therapy 10 years ago, who now comes in with new shortness of breath and is having some difficulty with increasing fatigue and some edema. They're not looking at that and thinking about heart failure. They're thinking, they're related to their cancer treatment, because they don't know to put those pieces together. So that workforce development is a critical component of interest that I have, and am looking at how we can build and develop that, those resources in communities for individuals, through the work that I'm doing with the American Cancer Society.
Yeah, excellent. And right now I'm sitting in a medical directed fitness center. So it's the Mercy One Health and Fitness Center that was built with the idea in mind of having it be a place. So not only do we have cardiac rehab, pulmonary rehab, cancer rehab, physical therapy, but we also have a full fitness center with a swimming pool and exercise pool and weights and exercise physiologists to support. So one of that leads me to kind of transition a little bit. We've talked a lot about rehabilitation, with the idea that patients have issues that we're going to try to make better. But let's shift to another important component of survivorship, and I would say that is health promotion. So how do we not just look at a problem and try to fix it, but how can we help prevent problems? And specifically, how can we maybe help prevent a second cancer by what we might call health promotion, in terms of paying attention to fitness, paying attention to nutrition, not smoking, sunscreen, all of the things that we know can modify our life in a way to reduce the risk. So that whole component of, let's call it health promotion or wellness. Talk a little bit about the research as it relates to health promotion as a way of improving quality of life, but also reducing the risk of recurrence of a cancer or reducing the risk of a second cancer.
Sure. I usually describe that and frame it around the pillars of lifestyle medicine, which is what you've articulated, really. The pillars, of lifestyle medicine, from nutrition and healthy eating, exercise, sleep, stress management, stress reduction, decreasing substance use, and social support. You think about those 6 pillars of lifestyle medicine. Every one of those have an element of evidence base that supports their benefit to individuals living with and beyond cancer. And by that, I mean health promotion for an individual who's a cancer survivor. Yes, treating those impairments like neuropathy and fatigue, et cetera, but really promoting better health. If we can encourage physical activity that meets guideline concordant recommendations for these individuals, we know that their risk for a second cancer will be diminished. There's evidence for sleep and behavior interventions. There's evidence for nutrition, healthy diet. One of the challenges that I think we face in this country is that right now, among the population of the United States, we're lucky if we see about 40% of people say that they reach or achieve the recommended physical activity and diet recommendations just for healthy living. So we need to do a better job as healthcare professionals, community members, neighbors, friends, family members in working towards those healthy lifestyle behaviors. It is a growing body of evidence, and we need to be able to bring, again, as a part of that wraparound service, how do we get individuals beyond cancer to exercise, eating healthy? What are the recommendations specifically? Sometimes weight gain, weight loss are challenges after treatment, after cancer treatments are finished. What does a healthy diet look like? We don't have as much evidence in that space. There's a lot of evidence, but not as much as we do for exercise, physical activity, accumulating that 150 minutes several times a week so that you can achieve that balance of healthy behaviors, eating well, sleeping well, exercising, reducing stress. All of that contributes to improved health outcomes for any individual, but especially important in those individuals who have suffered a cancer treatment, a cancer diagnosis, and have gotten through treatment. The evidence is strong to support exercise as an intervention in preventing 9 different types of cancers. 9. And I'll tell you, I was just reading the American Heart Association's new guidelines on recommendations about changing prehypertension. And they start with what I call mom and apple pie, right? Mom and apple pie is, we need to start with an exercise intervention. Lifestyle behavior changes are the most important thing. And then here's all the list of drugs that you use. But the medical professionals that are managing these individuals don't understand. Our physicians don't know exercise physiology. They don't know nutrition science. And that's okay. They don't need to. That's why I need to be in the room. That's why the dietitian needs to be in the room, right? We need to be able to find the resources that we can engage and bring and connect our patients to. The physician needs to give the advice, right? Here's what I think is really important for your health. Exercising, moving more, eating well. Here's the recommendation that I can give you, and here's who I'm going to connect you with to help you follow through on that. Maybe it's a health coach, maybe it's an exercise professional, a dietitian, physical therapist, depending on the level of need. But how do we make those connections stronger to bring those lifestyle and behavior initiatives towards reality for these people? The other problem there is the drugs get paid for, right? The exercise doesn't get paid for. Nobody's going to become a multimillionaire off of prescribing exercise the way that we do off of prescribing, statins or other medications for your heart or other body parts. So we have to think a little bit differently about providing the support. I recognize that my physician colleagues don't always have the knowledge and expertise in providing an exercise recommendation. And so when the patient says, well, okay, exercise, what should I do? Oh, now I have to answer that question, right? I've just opened the can of worms and now the worms are out of control. What do I do? But knowing where your resources are in the community, connecting. Wellness centers, what you have created is an absolutely phenomenal entity that brings together those services, right? All encompassing in one place. So the patient has access, so the individual has access and can get that acupuncture or massage or I mean, the massage is great, muscle relaxation, but it's also psychologically relaxing. It's again, a support system for the patient. Even though they may not call it a support group, it's a support group
Mhm.
when they come to a center like that, and all of those services are there. So I think we have to make it easy for our patients to access. We have to make it available so that the resources are there. And I think we have to nudge a little bit in encouraging folks to get there. We talk about cancer sometimes as the life changing moment, and people want to now take on new lifestyle behaviors. What a phenomenal opportunity to walk side by side with them, not just give them a brochure. Here's some things you might try, not just give them vague recommendations, but to really walk alongside them with recommendations for exercise activities to try, nutrition, diet changes to attempt. It can just be a simple thing to teach someone how to sear a piece of salmon rather than eating a deep fried, battered, fried fish stick, right? Those are very, very simple things that we can do, but we've got to have a mechanism to bring those around the patient.
Right. And the magnitude of improvement that can happen, let's just like one study just in the New England Journal of Medicine, probably the most prestigious journal, just a couple months ago, a randomized prospective study of patients with stage 3 colon cancer. Every patient had surgery. Every patient had 6 months of chemotherapy, and then the randomization occurred between just some education versus a regimented physical activity program. And
Mhm.
after 3 years, statistically significant improvement in survival. And in
Survival.
fact, if survival, and in fact, the magnitude of the survival was at least equal to the magnitude of survival of the chemotherapy. And most doctors and most patients, you know, sort of understand very intuitively how a medicine it might be beneficial. And of course, many people would rather take a pill than go to the gym. But the magnitude of improvement in survival by
Mhm.
having a regimented exercise program for colorectal cancer. You mentioned that there are 9 cancers for which there is conclusive evidence that physical exercise will improve the outcome. Do you want to rattle off those 9 that we
So
already have?
right. So that's for prevention. The evidence is strong around using exercise to prevent 9 different types of cancers. Oh, do I know them off the top of my head? Let's see. But I'll send you the paper. I'll post it in the chat.
Okay, okay. But
But
I mean, certainly breast, colon, prostate,
and some that you wouldn't expect.
endometrial.
Esophageal was one of the cancers,
Okay.
lung cancer. So there is strong evidence. But go back to your point here about the challenge trial. Yes,
Mhm.
probably for those of us in the physical activity exercise world in cancer, that was the most exciting. I was in the room at ASCO, standing ovation. It was a very exciting presentation to see that an exercise intervention, a randomized controlled trial, showed us that with routine exercise, supervised exercise prescriptions, that these individuals had a survival benefit. It's the first time we've ever seen that with exercise. The other and very interesting things that are happening in the exercise research world are around some complex cancers. The tumor microenvironment changes when patients exercise. Blood flow to the tumor changes when people exercise. So there's still mitochondrial pathways change when an individual exercises. And these are opportunities that we have to really demonstrate that exercise has the potential to come alongside our cancer treatments, potentially as an adjunct therapy. In addition to, I don't think
Mhm.
what we learned with challenges, yes, you see the exercise survival benefit, and we like to put up the numbers against the chemotherapy benefit, the potential benefit and survival, but it isn't one or the other. It was
Right.
really about the and, right? And that's what I think we need to be thinking about. So it was very exciting to see those results. The questions we're hearing now, well, this was only in colorectal. Does that mean we can do the same thing in lung? Is it the same thing in breast or in other cancers? And I think we have plenty of evidence that suggests supervised exercise prescriptions are very beneficial in helping individuals recover from cancer treatment, improve quality of life. This is the only trial that we've seen so far that shows survival benefit. And that's a big and challenging outcome to measure against.
But you make such an important point that even if in lung cancer, it doesn't improve the overall survival. The old school way is, I'm sorry you have cancer, take it easy. Don't strain yourself, take naps, eat bonbons, and we weren't doing anyone a favor, because the studies show that if you engage in healthy eating and physical activity while you're going through chemotherapy, you actually will have fewer side effects, and your quality of life will be better. Now, we hope that we'll see more studies that actually show survival is better, but clearly just reducing the side effects and improving quality of life is an endpoint that makes it worthwhile to incorporate with every cancer, regardless of whether we actually have a randomized prospective study showing improvement in survival.
Yes, yes. And when do we start? Ideally at the beginning. I'm going to put a plug in here for the concept of prehabilitation, which has, again, an emerging body of evidence. I'm working on a panel right now developing a guideline around the evidence for prehabilitation. What does that mean? Many times when we diagnose cancer, we identify it, we make the diagnosis, and then there's a period of time during which we do an extensive workup. There's scans and testing before we begin treatment. Sometimes it's weeks that go by, days and weeks. And so initiating an exercise, nutrition, stress management program then initiates the behavior and lifestyle change, brings about and helps to engage the patient in those activities before they even start treatment. Not only does that help with adherence, lifestyle change over time, the endpoints that we've studied there, days of hospitalization, recovery from surgery, tolerance to their chemotherapy, individuals who start with exercise at the point of diagnosis in a prehabilitation model do better in some instances, their performance in lung cancer, in colorectal, and other types of cancers. We're going to see those guidelines come forward for prehabilitation. So from the point of diagnosis, what's your exercise prescription? It needs to be part of the care plan, just like the dosimetry is a part of the care plan from the beginning, just like the care plan for chemotherapy. It's all there. Exercise is going to need to be part of that with prehabilitation.
Yeah, great point. We're going to open up to questions now, Nicole, if that's okay with you. We've got a live studio audience, so they get to have first questions. But if you are watching us live streaming right now, you can put your question into the comments section of the software that you're using. But Kevin, you get the first question.
Yes, most people will think that somebody who had a cancer diagnosis and then was declared cancer-free after the treatments would be happy and full of gratitude. In most cases, I'm sure that's it. But academic cancer, certainly there's a mental health availability. I was wondering if the American Cancer Society knows that what the incidence of suicide might be among cancer survivors, and if it's any different than the general population, and what might be the cause for the difference.
Yeah, that's an important question. We certainly, I don't know that we specifically have epidemiological data on the prevalence across different types of cancers. But we do see, I will speak to anxiety, depression, especially in the survivor population. The other group that I don't want to leave out in that discussion about mental health is the caregiver, because those individuals also suffer significant anguish and burden in walking alongside their loved one. So the mental health services are absolutely critical to bring those alongside, and recognizing that fear of recurrence, being down, how are we screening these individuals individuals, really to make sure that we are identifying those who are at the highest risk. And also, this comes with our medical providers understanding the late effects and the long-term sequelae after cancer treatments. So I think it is an underserved area in mental health. And there are some places where there is research ongoing about early identification and management of especially anxiety and severe depression in these individuals. Again, the simple answer sometimes is give them medications, right? Antidepressants. But there is evidence that social support networks and social support systems can be helpful. How do we identify those people who are at greatest risk and put them into situations where they have those wraparound services that can be most helpful?
Yeah. Excellent point. And as you've already made the point, a survivor, may be cancer-free, but may have just all sorts of physical, but psychosocial, emotional, financial, sexual, philosophical issues. But you put all of those together, cancer-free, but, dry mouth, stiff neck, difficulty swallowing, and financial toxicity related to copays and deductibles, and all of that together can be a pretty urgent situation in terms of need for intervention.
Yeah. And I think one of the things we are focused on to this point is health-related social needs and doing a better job of bringing screening tools into clinics so that we're better assessing people's socioeconomic status, understanding those financial challenges, understanding the community services that are available to manage the health-related social needs.
Another question?
That kind of piggybacks on the discussion that you're having, and it's more on the front end as far as people adopting and living a healthy lifestyle from early in their lives. They have to believe, literally, they've got something to live for. I mean, it's figurative, but it just seems to me that that's really important. And does the American Cancer Society partner with anybody else, or do you do anything to improve the lives of people pre-cancer so that they don't adopt unhealthy lifestyles that lead to cancer?
Yeah, we work very closely in our communities with our community impact staff, community organizations around the country in exactly these things, bringing these lifestyle and behavior interventions into communities. You may be familiar with some of our events like our Relay for Life, which is about creating community, creating a support event around exercise and activity. It's a great example of things that we're doing to try to partner with local organizations, bring people together and around something like a physical activity intervention. But I think to your point, even further is the idea that how do we identify individuals, what is meaningful to people, right? What is meaningful to an individual? I don't think we have enough conversations about that as we're starting cancer treatments. It's a very stressful time. Patients are hearing words and things that they've never heard before. They're terrified. They're facing challenging decisions that they probably do not feel empowered to make decisions, but they have to be made quickly. And I think that in some of that, we lose the human connection and the connection around what is meaningful, what is important to that individual, so that we can help them to remain focused on the things that do bring them joy, the things that they want to get back to in life. It's one of the things that I pride myself on the most with rehabilitation is the rehabilitate part. I had a patient say to me one time, my doctors might have saved my life, but you gave me my life back by giving me the ability to see that I could do more things. You gave me the confidence to try to do more things. You gave me license to exercise, to become more active. And I think we need more of that up front. The more that we engage at the point of diagnosis, the more that we engage people around the meaning in their life, the things that are important to them, their goals. If we understand that human being, that connection is made, we can better meet those needs and address those things as they go forward through treatment. So that's always up front in the work that we do, is touching lives. I mean, that is one of our primary metrics that we look at as an organization. How many people do we touch with the services that we offer, not only for the patients, but also, as I said, for the caregivers. When you bring the caregiver along in the conversation from the beginning, that in itself creates a beautiful support network. And the caregiver sometimes is not only a spouse, it can be it can be a parent, it can be a son or a daughter, it can be a cousin, it can be a neighbor, it can be a church member. So we really do bring the resources to help individuals with coping, with support, caregiver resources that we have. I mean, the American Cancer Society, the resources that we have on cancer.org are tremendous around lifestyle engagement, mental health support, resources for social support. We also have, you can call our 1-800 number and we can connect you to someone who can talk with you about the situation that you're in. We look to try to do a peer-to-peer matching with some of our cancer survivor support line. So we do try to bring those services forward to the communities where we are in.
Yeah, and Nicole, you make a point of the services the American Cancer Society has. Maybe give you the opportunity to talk a little bit about the new app, the ACS Cares, that's
Yes.
available for patients to, access not only peer support, but also to access all of the resources that might be in their own zip code.
Absolutely. So ACS Cares is an app that is individualized. We do a screening at intake. People set up a personalized profile. The screening that we do at intake is based on the distress thermometer, which patients are usually very familiar with, asking about everything from physical problems to family problems, emotional problems, sleep, nutrition, etc. And by selecting the items, the algorithm takes them to specific resources, helps them with decision support, information, helps them to connect to another peer potentially to help them. We've also have had the privilege over the last year of working with the ACS Cares team to help to create a new intake and a new pathway for caregivers, so that the caregiver sometimes coming to the app, sometimes they're looking for information for the patient to help with decision making or finding information, but sometimes they need help themselves. They need support. They need coping strategies. They need to be able to manage the stress, the anxiety that they're feeling. So ACS Cares is a wonderful tool. It is an app that you need to download on your phone and set up but it does give you a really nice personalized approach. And the resources will guide you to cancer.org, because we believe that we are probably the most trusted resource for cancer information in the United States, maybe even in the world. We do significant diligence on making sure that our content is high quality and accurate. So we do provide those resources. The other resource that we provide is through findhelp.com. And we have a process by which we will work with organizations to get them set up into findhelp.com, so that if somebody calls our National Cancer Information Center with questions, if we don't have the content on cancer.org, or we don't have those local resources to connect you to, we can connect you through findhelp.com to identify the local, like you said, right in your zip code, who's there in my neighborhood. You may not even know that you've got a counseling center down the street, or a dietitian who's an oncology specialist, a couple of blocks away.
Great. Well, Nicole, this has been great. We have run out of time. We definitely are going to have you back to continue this conversation. Our guest tonight has been Nicole Stout. Nicole is the Senior Director of Survivorship and Wellness at the American Cancer Society. Thank you for joining us.
Oh my goodness. Thank you. This has been such a wonderful conversation. I've really appreciated it. Thanks for the great questions, and everyone have a great evening. Enjoy the rest of your evening. I heard you're all in for some great exercise and some good food. So enjoy.
Yes.
Yeah.
Thank you. And if you're watching our show tonight and you know someone that would benefit by watching it, the good news is it's going to be available on demand beginning tomorrow. You can find this program and watch it at the Above and Beyond Cancer YouTube channel or the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.